clinicians bring varying perspective and experience to managing patients living with MS. Nurse practitioners June Halper, Jim Quinless, and Megan Weigel discuss their individual approaches to managing patients and share unique insights into their role on the healthcare team.
Hi, I'm June Halper. I'm a nurse practitioner and I work for the Consortium of MS Centers and the International Organization of MS Nurses. It's great to see you guys again. I'm so glad we had time for some coffee.
Great to see you, Jim and June. I'm Megan Weigel. I'm a nurse practitioner at Baptist Neurology in Jacksonville Beach, Florida, and I'm the current president of the International Organization of MS Nurses.
Yeah. I'm Jim Quinless. I'm a nurse practitioner at Rutgers University, New Jersey Medical School in Newark, New Jersey. I've been practicing as a nurse practitioner for about 22 years now.
I guess we're the old-timers, Jim.
That's right.
Yeah. It's great to see you again, Megan. You know,
Thanks,
we're glad you came up north to see us.
Absolutely. You stopped the snow for me.
Yeah. It's been a tough winter up here, but the weather's been bad. But how have you been doing?
Doing really well. Yeah,
Good.
doing well
Yeah.
down in Florida.
Yeah. Things have changed, huh, Jim?
Absolutely. Again, the good thing is that we have tremendous medications for multiple sclerosis. Probably the best thing is that we rarely see a relapse. I rarely use steroids any longer. But it does present other obstacles and challenges.
Sure. Yeah. How do you explain a relapse, Megan, when many of your patients, I know you're so new in the field, but, you know, do you teach a patient that they might have a relapse, you know, and...
Yeah, you know, it's hard because you have to, just by nature of the disease, talk to patients about relapses. But what I find is that people living with MS often confuse a bad day with a relapse.
Right.
And so I try to talk to patients about keeping a journal of good days, medium days, and bad days. And when any new symptom happens, that's, you know, when they need to call. But it's very, even in, say, people who've had MS for decades, that pseudo relapse just doesn't seem to be much on the radar. It's people really seem to want to call bad symptomatic days relapses. So it's difficult.
Yeah.
Right. And then do you have to bring them in? Because I know, remember years ago, you know, we used to have either bring them in or go to the emergency room, but do you actually try to see them?
I do try to see them. I'm in private practice in Jacksonville, and we do have the luxury of being able to make some space in our schedule within a few days for people. So I do try to bring them in if it's not something that I can talk them through on the phone and we can figure out on the phone. Sometimes it's just that. It just requires some education of what we have a lot of issue with in Florida is the heat. So oftentimes someone will go to Disney World with their family and then their legs will be weak for a couple of days and it's just, you know, well, rest, hydration, it's not a relapse, and then we'll schedule them to come in when they're feeling better.
Yeah.
In the olden days, we used to have nothing except, you know, symptomatic management and relapse management. But how do you handle, you know, because we're from the older generation, but how do you handle the number of drugs that are out there, and how do you educate the patients on the various choices?
Well, gosh, that's all of us doing that,
right?
Yeah. It's a difficult appointment, and in fact, in my practice, we typically deliver the diagnosis and talk briefly about how hopeful it is that we have so many disease-modifying therapies, and we may order some blood work and talk to them about medical comorbidities so we can perhaps take some of them off the table and then bring them back. How about you, Jim?
Yeah. I think, too, we have the opportunity to offer them options. I mean, you kind of have to narrow it down, you know, but they do have some empowerment. They can choose a medication that might fit their lifestyle.
Right.
You know, again, I think we have more options for patients. Getting back to the issue with symptoms, I always find that a difficult area because patients, you know, they don't realize that if it's just a temporary symptom, it's really not a relapse,
Right.
you know. So, but again, it's a good opportunity to speak with patients, you know, to get their thoughts on how they're feeling. And again, I think the most important thing that we do is, you know, actually listen to the patient.
Yep.
You know, what's going on. The MRIs are wonderful, the medications are wonderful, but you really need to sit and listen to your patient, whether that be by phone or having them come in to the office and speak.
I agree.
Yeah.
I got a call the other day from someone who's been on a disease-modifying therapy, an injectable, for many years. And she called to say, do we have any policies to advise patients about switching to something more convenient? How do you handle that? If you've got somebody stable and everything's doing well, but they're sick and tired of injecting themselves or going for an infusion, and now they want a pill. What do you do?
That's a tough one sometimes. They might not be at a level where they need to go up to the pills.
Right.
You can consider some of the circumstances of risk on the oral medication. So
Right.
that's the real challenge. I mean, patients have to realize, you can't stop. There's no drug holidays. I know that sounds harsh and everything,
Yeah.
but that's the real challenge for us, to keep the patients on medication no matter what.
No matter
Right.
what.
Yeah.
And I think that with the advent of oral therapies and IV therapies, that's when this concept of shared decision making has
Sure.
come in with patients. And so we have all these treatments, but what we don't have right now are biomarkers to know
Right,
who does
right,
best on
right.
what treatment. So when a person's doing well on their current therapy, if the reason that drives a change is the patient isn't happy with the way their current therapy fits in their life, I
Right,
always,
right.
I say, okay, well, let's look here. You haven't had relapses in years. Your MRIs aren't changing. Your disability level has not changed. So there is some risk in making a change to a drug with a different mechanism of action. And if you're willing to take that, then, then we can
Yeah.
do that. But know that risk is there, since
Yeah.
we truly don't know.
Yeah, and I know the generation of nurses that that you represent, it's like it's there and it's natural. It's when we came from. We were so blessed when they started to come, in the early '90s, that things are, we every day it's like a miracle to us. But it's. I think a bit of a challenge when I meet some of the younger nurses and they don't look at things like symptomatic management. There's such a rush to get patients on therapy that sometimes they don't look at, as you mentioned, the comorbidities
Sure.
or issues of lifestyle. They just, let's get the patient on, because that's been the drive with
Right.
research now, early
Yeah.
treatment and early
Yep.
treatment, yeah.
Yeah, and again, sometimes the worsening can be very insidious. Again, it's a real challenge to follow these patients and pick up subtle changes. Sometimes the MRI is not enough.
Right.
The careful neurologic exam is not enough. It's listening to the patient
Yep.
and kind of watching for changes, as subtle as they may be. But
Yeah.
I think that's our real challenge.
Do you find any of your patients use some of the electronic stuff? Because I know a lot of the centers now, like John Foley out in Utah, is using an app, where patients can monitor day after day.
Yeah, I do encourage them to use an app if they find it helpful. Some people do prefer to write in a journal.
Right.
And unfortunately, in our practice right now, we don't have the ability to download that information.
Sure.
And so to really make it useful for me, it's something that I have to scroll through with the patients. But I agree with Jim in that just talking to patients and that listening to them subtly over time continue to complain of the same things, and maybe they are worsening.
Sure.
Something that you really need to think about. I think one of our greatest challenges, kind of in a more wellness-based model, is suggesting to a patient that actually what might be happening to them is the result of their cardiac disease or their diabetes,
Sure. Yeah.
and not their multiple sclerosis.
Right.
And that there's an impetus for them to, self-empower and healthy up their lives. I find that to be a challenge.
Yeah, we were talking earlier about Narcoms and the registry and all the information
And so
we've
much.
gotten, about smoking and obesity and vitamin D and exercise. I mean, it's changed so since when we first started in MS, people were told to rest a lot.
Yeah.
Yeah, don't get overheated
Yeah.
and rest a lot. And
Yeah.
now we know that's hogwash.
Yeah, yeah.
Yeah, it really is.
I find patients that are active do, exceptionally well compared to other patients that are less active. I think, exercise is just tremendous for patients.
It is.
Just for a sense of well-being, it sort of helps with all the symptoms of MS. I think it helps with cognitive
Yep.
difficulties.
It's a great antidepressant.
Yeah, absolutely.
Without the
Yeah.
side
Better than,
effects.
yes, absolutely.
But talking about cognitive, I mean, I know you and I had a conversation a few weeks ago about the screening tools and for cognition. Isn't that a challenge? I mean, in terms of being able to help a patient where they say to you their memory is bad, they're
Yeah.
having problems processing new information. I mean, what do you guys do with that? And there's such a shortage of mental health services and, the psychological help that patients need. And reimbursement is a real
Yeah.
issue.
Yeah.
How do you deal with that?
The cost of neuropsych testing is really expensive
It's
and
expensive.
prohibitive. That's one of the challenges that I find, one of the
Sure.
more difficult challenges. Send them to a psychologist, refer them, again, sometimes just help them with, trying to identify where their difficulty might be. Maybe it's just in concentrating or remembering and, give them a little exercises to do, but that's a challenge.
Yeah.
I'm coming up short with a good answer.
Yeah, sometimes I'm relieved when an older person with MS begins to complain of cognitive issues, because then I think, well, we might have some pathology we can treat.
Yeah, we are almost hoping that. Yeah.
But in my younger patients, I don't think that we use cognitive rehabilitation very much, because the tools that they can give can be given by a neuropsychologist, but I really try to talk to my patients about adequate sleep and about the effects of nutrition on their energy level and mental health,
Sure.
depression, anxiety, and see if there's any deficits in those areas that we can work on that can help.
Right.
Perhaps increase their cognitive abilities.
Well, I think, your talk every time we have an annual meeting or a regional program on yoga, I think, and again, I know research is sort of fluffy in that area, but I really do believe in that wellness model and the yoga and the meditation. And the more I hear about it, the more I think that it's an unexplored region that nurses should get into, particularly the NP, to try to encourage patients to develop some strategies. Listening to you, it's
Yeah.
not that hard and it's not that long that you would need to spend with the patient to give them those tools.
Well, and the luxury for us as nurses is that we tend to have that time to spend
Yeah.
with the patient, and probably even more time, I would say definitely, than some of their primary care providers.
Oh, yeah.
And I almost sometimes think that having multiple sclerosis can offer patients opportunities that people without chronic disease don't get, to learn about wellness strategies and,
Right.
and things like that. I hear from patients who bring their care partners with them to meetings and stuff that they always leave learning
Yeah.
something that they can implement into their lives too.
I always try to order physical therapy, always, and sort of use that as a segue into the patient. I'll get some feedback from them. They say,
Yeah.
I felt really, much better with that activity, and then maybe help them get into some kind of exercise program or anything. But
Sure.
but lots of physical therapy. That's
Lots.
one of my favorite
Me
treatments.
too.
Yeah.
Me too.
Yeah. Who do you do? Have anybody in-house where you work?
Not where we are.
Not where we,
Yeah.
well, we
Yeah.
have our hospital-based outpatient physical
Yeah,
therapy,
yeah.
but we have some we have an excellent physical therapy school in St. Augustine, Florida, actually, and so we have some very good, not only rehab and hospital-based practices, but private PT practices.
Yeah.
So I feel like I know when a person has this problem that this practice is going to treat them best and
Oh, that's
can
good.
kind of shuttle
Yeah.
them where they need to
Yeah.
be.
Yeah, we recently did a meeting for PTs, and we really had a full house. There's a lot of interest today, I think. Years ago, PTs didn't want to touch patients when we first started because they figured there's nothing you can do. But today, I think with all the meds and the hope, as Jim was saying, we're
Yeah.
seeing, I know I go to meetings, and there are fewer wheelchairs.
Yep.
I think fewer walkers. And so one of the nurses called me the other day, one of our friends, about wound care. I mean, you don't hear that
No.
much,
Right.
right?
No.
It's so different. It's so different. It's like the ancient times.
Right.
We ought to write a history book to keep it, yeah. So what do you find is the biggest challenge in managing, working with people with MS?
I think it's time. I could always spend more time with people.
Right.
And I also think it's the lack of mental health resources.
Yeah.
I think we know that depression and anxiety are so prevalent, probably even bipolar depression and multiple sclerosis. And because of reimbursement, many mental health professionals aren't taking Medicare anymore in my area.
Oh,
It's just
really?
very hard
Wow.
to get people involved in counseling. And I personally think that probably every human being could use a little counseling.
Oh, sure.
So,
We need each other too.
Right.
That's why we're sitting around having coffee.
Yeah, that definitely is a challenge, at least even to have the patient have like a counselor, a psychologist. You're always quick to maybe prescribe an antidepressant, but maybe that's not going to be so
Right.
helpful. Again, the pathophysiology of MS lends itself to depression.
Yep.
I mean, that's cognitive, and then, it overlaps into fatigue and all kinds of issues. So that's another difficult area, definitely.
and here's something I just thought of, but in my era, social media is a big thing. So one of the other difficult challenges is trying to provide a patient with recommendations, say for a disease-modifying therapy that you think is best for them, or dissuade them for one that they think is best for them because they watched a YouTube video.
Right.
Yes, yeah.
And that N
Yeah.
of one
Right.
had, a miraculous
Yes. yeah.
occurrence.
Like stem cells that they're going,
Yeah.
everybody's seeking that, although they're not approved, yeah.
Right.
You're right, you're right.
So that's
Well,
a
when we
challenge,
first
too.
started in MS, it was cobra venom.
Bee
Remember that?
sting
Bee
Yeah, bee
therapy.
stings,
Yeah.
right?
I
and
think I
we've been-
came in at the end of
Yeah.
the bee sting era.
Yeah, so it's a little different, yeah. The bee stings were around from Florida, actually.
Yep.
The hives came
Yep.
from
Yeah.
Florida,
Yeah.
yeah. Well, it's wonderful to get together. We'll have to do this more often.
That sounds
Very
great.
good.
Really
Good to see
good.
you guys.
Very good.
Yeah,
Thank you.
excellent.